In this video, we're going to talk about several things, the first being depressive disorder and bipolar and related disorders. We're also going to cover a little bit of information about suicide assessment and potential hospitalization processes. So let's first start with depressive disorder. Rather than go over some of the symptoms, I do want to refer you directly to the DSM to look for the very specific criteria for major depressive disorder. The one thing that I really wanted to mention when it comes to depression is to make sure that you're aware to look for differences between adults and children or adolescents in terms of how the depression presents itself. Lots of times with kids and adolescents, depression can manifest as aggression or irritability, certain outbursts that they have, anger outbursts. And what I would suggest that you do, if you're seeing kids and you know they're having these outbursts, that you perhaps consider major depressive disorder rather than things like disruptive mood dysregulation or oppositional defiant disorder or the intermittent explosive disorder. I want you to think about and consider depression as opposed to those. Although that they could be relevant, I want you to think about depression and if this is a manifestation of that with the kids first. In essence, what it is, the best way I could describe it is that the anger that they have is directed outward toward others rather than inward toward the self, which you will typically see with adults, older individuals. They have that a certain unhappiness or sadness that's characteristic of depression, and it's a certain feeling, that irritability, the aggression towards themselves. Perhaps is the way the behavior will be manifested. So with kids, they haven't fully developed cognitively, and that anger is pushed externally rather than internally, which is why you do see the aggression, the irritability, and the physical outbursts of anger with kids. Now, some adults act this way too, and it perhaps might be related to where they are cognitively, their level of self-awareness. So it's something you may want to consider for adults as well. For the full diagnostic criteria, please refer to the DSM. So let's move on to talk a little bit about bipolar disorder. And again, without getting into specifics of the diagnostic criteria, referring you to the DSM, I want to encourage you or make this general recommendation to be very careful of this diagnosis. And it's based on my personal experience as a clinician. I have a certain lack of trust in other professionals sometimes as a result of inheriting clients that have some type of diagnosis of bipolar disorder when actually I did not think they had bipolar disorder. I want you to understand what the symptoms of mania and hypomania look like. In my opinion, this has really been immensely overused, overdiagnosed in recent years. I want you to look for whether or not this irritability that are typically seen in kids that will be given this kind of label, is that actually symptomatic of something else? Is their emotional regulation or their lack of ability to regulate their emotions, is that due to something else and not bipolar disorder? If you could really help someone gain better control, better management of their emotions, to me, this means it isn't bipolar. And I would suggest you look at the diagnostic features on pages 127 through 129 of the DSM for a good description of what mania actually is. When it comes to bipolar disorder, as you are conducting your assessments of individuals, is you certainly want to ask about family history, because a family history of bipolar disorder does put individuals at high risk for them having bipolar disorder themselves. I have talked with lots of clients who have kind of self-diagnosed themselves with bipolar disorder because they think they have it, or based on what they think they've heard about it. Other people that they know, they'll automatically leap to the conclusion, oh, well, I've got bipolar. So be skeptical. Look for the actual scientific, if you will, criteria when it comes to diagnosing bipolar disorder. And do not take the word of another clinician or your client. I want you to make this decision for yourself. Now, if it's a clinician that you trust and trust their judgment, then you can certainly lean towards continuing that diagnosis of bipolar. But I just encourage a healthy degree of skepticism so that we don't perpetuate this overdiagnosing of bipolar disorder. And that's it for what I wanted to cover with depression and bipolar. Again, refer you to the DSM when it comes to the criteria for those two particular diagnoses. So we're going to transition into talking a little bit about suicide assessment. And if you've already taken the consultation class with me, or you're yet to take it, this will be somewhat repeated information, but in my opinion, when it comes to suicide assessment and getting comfortable with it, knowing how to do it, what to look for, what to ask, you really can't go over it too many times, because it is a stressful thing to encounter as a clinician, and I want you to be as prepared as possible. So we're going to start with an acronym that will help you to get a basic underlying foundation or assessment of a client and their potential lethality. The acronym is SLAP DIRT. So each one of these letters stands for something else. So we're going to start with SLAP. If you're encountering a client that you feel like is at risk, I want you to be comfortable in just flat out asking them, are you thinking about killing yourself? Are you thinking about hurting yourself? Don't hesitate. Don't be timid when it comes to asking that question. It is a perfectly reasonable question. I've never encountered a client in my own practice that has been offended by me asking that question. Think about it this way. If a client is thinking about suicide and you didn't point blank ask them, even though they have hinted at it, what type of a message do you send to them by not asking about it? Simply because you don't want to offend them or that you're timid. You can send a pretty negative message. Perhaps you don't really care. We want to avoid projecting any type of message like that in this situation. So SLAP DIRT, acronym, a mnemonic device intended to help you remember this information that you might need to gather. And there's other ones that are out there, but this is one I would encourage you to keep tucked away in your mental file. So the S within the SLAP stands for specific plan. You want to know if they've thought about how they might do it, where they might do it, when they will do it. Now, if they have a very specific plan, that is where you should be more concerned. If they don't have any specific plan that it could be a little more passive in nature. They certainly have the thoughts, but they don't know maybe how they would do it, or where, or when. That certainly is part of your assessment. What you want to be on heightened alert for is if there is a very specific plan. L stands for lethality. How lethal, how deadly is the plan that they have? Because it can range from one thing to another. If we're talking about something like a firearm that would be involved, those can be pretty lethal. That would be of more concern. I once was a firefighter. I was a firefighter for about 10 years, and I used to respond to lots of calls when it came to attempted suicide. And I remember showing up one time to a gentleman who had tried to hang himself using a belt, and he had hung the belt buckle on a nail that obviously was not a large enough nail to hold his body weight. So when he kicked out from underneath his feet, whatever he was standing on, essentially the nail just bent down and he fell to the ground. So we essentially took it as certainly this is a gesture, a suicidal gesture, but it was not really a lethal plan. He was at risk, obviously. But the lethality, by definition of what he did, was not extremely lethal. This was more of a gesture, a cry for help. There's still things you need to be concerned about. But the more lethal, the more deadly the plan that someone has, obviously the more reason to be concerned, highly concerned. A stands for availability of means. Availability of means. Do they have what they need to carry out the plan? If they intend on shooting themselves, do they actually have a firearm? Is the firearm at their house, or do they know where they will obtain the firearm? And you will, for working with kids, you'll often encounter them talking about suicide, and certainly the lethality of their plan could be very deadly. But in terms of them having access to whatever it is that they plan on doing, they may not have access. So certainly it's less risk if they don't have those means available, still at risk because they're thinking about suicide, planning on it. But the greater the availability of means, the greater they have available to what they need to carry out the plan, the greater the risk. P stands for proximity of help. So how close is help to them can indicate how determined they might be to commit suicide. Is it someone who's kind of gone off in the woods, away from someone in order to shoot themselves, or is something, the gestures that they are involving, is it something in which people are readily around that could intervene? I'll tell you a story of someone I worked with. I was just starting in the profession, mid-90s, early mid-90s, and it was a 15-year-old, and I worked in a hospital setting at that point in time, and this 15-year-old had been hospitalized multiple times during my even brief tenure at the hospital. He'd been in and out probably 4 or 5 times, and he had this pattern or routine of when he would, people thought he was doing well, he would be ready to be discharged, and back then kids would stay in the hospital for a minimum of 30 days. That's just what insurance by default paid for back then. He'd be, close to the end of his time in the hospital, close to his 30 days. He was doing better. People thought he was doing better. And he would attempt to hang himself in his room. What we discovered, because it happened repeatedly, is that he would shout out just before kicking the chair out underneath him. He would shout, he would call for help. So we knew if he called out, he needed to run down and cut him down, essentially, in order to save him. So obviously he wasn't necessarily serious about killing himself. It was always essentially a cry for help. You can't ever take that chance. You can't not respond simply because you know it's a cry for help. You never know how far the client might go. But that proximity, him knowing how close help was, even though a very serious attempt, serious intent, his knowing that people were so close by, he really was perhaps a little less at risk. Now, I share this story and kind of all these caveats about always taking it seriously and trying to discern whether or not someone's actual intent. I will share with you that this individual teenager was successful in killing himself when he was referred to long-term treatment. That the folks at wherever he was, we heard word after he had completed suicide that he had attempted the same thing. They hadn't bothered to read the notes, obviously, that we had sent forward with him, and he was successful in killing himself. So, again, you always have to take these things seriously. Even though he probably did the same thing, help was probably close by, they just didn't respond. These are not the types of things that you want to carry with you as a professional as you move forward in your career. Now, the dirt part of this assessment, SLAP in itself could be conducted very quickly. You're asking questions to determine their plan, how lethal it is, how available the means are, how close help might be. You can briefly conduct this informal type of assessment to get a gauge for how serious the risk is. Dirt is something you add to this assessment if you know that there has been a previous attempt by your client, previous attempt to kill themselves. So you follow up SLAP with dirt. And the D here it stands for how dangerous were the previous attempts. Are they more determined now? So if you think about that client that I just shared with you who committed suicide, the attempts were dangerous, yes, in the past. How determined was he? Maybe it could be argued that he was more determined once he had gone to long-term treatment. Just through conversation, if someone had sat down and talked with him, you could have asked him about all these previous attempts and follow it up with essentially a question, well, how likely is it you think you'll do it this time? Or how determined are you to really make sure that you follow through? How badly do you want it to happen? You ask these questions, point-blank questions, to try and obtain this information. You can't take an x-ray to know what their thoughts are. You have to ask them. I stands for impression. What is their impression of their past and their present danger? What do they think about how at risk they were in the past and how at risk they are now? How dangerous? How do they feel about it? What do they think? R stands for rescue. Getting some details about how they survived their previous attempt. So the client I mentioned before could share with you, well, I would always get cut down before I choked out. So as a clinician, you would know, if someone hadn't been there to stop it and to cut him down, he would be dead right now. So you would need to be on extremely heightened alert for this being a very serious attempt. He could easily hurt himself. And T stands for timing. What are the certain events that perhaps precipitated the past events? Was it a recent breakup? Was it a fight at home with parents, or whatever the case might be? What was the timing of the previous attempts? And as a clinician, you want to think about, well, what are the circumstances right now that are perhaps causing them to think about hurting themselves? Is it similar? Could this very well be a pattern that could be repeated? And that, in essence, is slap dirt. So I'm going to go over an additional one that you can use. Hopefully this will all fit on a slide. I'll try and write a little smaller here. And this one refers to the acronym of SAD persons. All right. Again, mnemonic device acronym SAD persons. S in SAD stands for sex. Really, we should say gender, but S fits. If they are a male, that gets somebody a point. Males are at greater risk for completing, being successful at suicide. A stands for age. So if the individual is less than 19 or greater than 45, they get a point. I'm just going to put +1 over there because every criteria that I mention here are going to be how you obtain a point. So if the individual is under 19 or over 45, they are also at greater risk. The D stands for depression. You could say depressed or depression. Are they currently depressed, or do they have a history of depression? Have they been depressed in the past? Whether it's past or present, you get a point. And this would be significant depression. Everybody gets down from time to time. But someone who might meet the criteria for major depressive disorder, that's worth a point. So the criteria here would be, yes, that's how someone would get a point. P under persons stands for previous attempt. Again, yes is the defining criteria here. If someone has attempted suicide in the past, that is worth a point. E stands for ETOH, which is another way of describing alcohol abuse. If the person is either currently abusing alcohol or has previously had an issue with abusing alcohol, they also get a point. Puts them at greater risk for attempting, at least. The R in person stands for rational thinking. This would be no. If they are not thinking rationally, you could define it as Albert Ellis, rational thinking, or just in your basic judgment as to whether or not someone is thinking rationally. If the answer would be no, that would get them a point. S stands for social support. So if the individual that you're working with, if you know that they don't really have too many sources of social support, that would get them a point. If they are isolated, lonely, feeling lonely, whether or not they have tons of friends or not, if they feel a lack of social support and they have no, that's worth another point. O stands for organized plan. And this is very similar to the S from SLAP, the specific plan. You want to know how, where, when. If they have a very organized and specific plan, if the answer is yes, that's worth a point. N stands for no spouse or partner. It's kind of a double negative here, which could be a little confusing. But if the person does not have a primary significant other, we're talking about adults here, obviously. If that is not present, then they get a point. And then S stands for sickness. If the person is suffering from a chronic or acute illness, is in a great amount of pain, or has perhaps a poor prognosis or outlook, any of those things with a yes, that's worth a point. Now, in terms of scoring, so to speak, when it comes to this assessment, if a person scores 0 to 4, that is considered a low risk. Does it mean that they are not out of the woods and it could never happen? It's just essential low risk. Between 5 and 6 is considered medium risk. And 7 to 10, high risk. Now, we can't really make blanket statements as to what you should do given the level of risk. There's really never any guarantee or assurances that you can make in terms of someone's safety. I think what I would perhaps suggest that you use this in clinical practice is that if you know there is a medium or high risk in this individual, then it probably should be very indicative of what you should do to ensure their safety. Low risk, you may still need to do something to ensure their safety, but you may not. You'll have to really, with all these things, just explore a little bit further and develop things to put in place to perhaps assist with ensuring safety. But again, no guarantees. And probably you should be a little more certain as to what you should do with someone to ensure their safety if they're at medium or high risk. Just my opinion. So let's talk about those next steps. When you do make a decision that you're concerned about someone's safety, you can't just send them home or send them about their way. What do you do then? Well, if you're going to end up being a school counselor, you have or will likely have something at your disposal that most school systems have in terms of a very specific protocol that you need to follow. And I would encourage you to follow that protocol, something you should get trained in the minute you start practicum or internship. You'll at least be able to observe other school counselors going through their protocol and assessing for suicide risk and what to do next. For everyone else, mental health majors, career majors, you find yourself in another type of setting, you're concerned about someone's safety, the very first step that I would encourage you to do is to consult with another mental health professional. 2 heads or more than 2 heads are better than one when it comes to suicide assessment. You talk about what it is you're noticing, the presentation of your client, the things that you have assessed, what the results of your initial informal assessments were. You may have to develop a plan or protocol about not leaving the client alone while you talk about these things. Someone always keeps an eye on the individual so that they aren't doing something while you're not watching. But consult. Come up with some type of plan or decision. Now let's say you come to the conclusion that this person needs to be evaluated for potential hospitalization. The process, to my knowledge, has remained relatively unchanged in North Carolina. This is a North Carolina thing I'm getting ready to mention. But it may vary, and it could be that after recording this lecture that things will change. So you'll want to investigate current procedure, protocol with wherever you find yourself practicing. What would be the steps you'd need to take? But if things remain unchanged and you practice in North Carolina, this is what tends to happen. In terms of getting someone hospitalized, which is the surefire way to ensure someone's safety, it's a two-prong or two-process of assessment. And it will need to be conducted by either a PhD level psychologist or a medical doctor. So we're a PhD psychologist or a medical doctor. Those are the ones currently, and this may change in the future, those are the ones who are currently eligible or credentialed to provide these assessments for hospitalization. There's been some talk lately about LPCs being credentialed to do this as well. Don't know what the outcome of that will be. Right now, it's PhD psychologists and medical doctors. These assessments can be completed at either a hospital or a designated location, which used to be a county mental health center, which are no longer present in North Carolina. They became the LMEs, the local managing entities. But it very well could be some other type of facility or location that has the appropriate people there, and their designated locations of crisis intervention. For most people, the initial step is to refer them to the hospital. Now, if you're in private practice, just for example, or you're in a private agency, more than likely, your first step is to call the local law enforcement if an involuntary commitment needs to be initiated. If the person is voluntarily willing to go to the hospital, then by all means, that's okay. They can walk themselves there, or drive themselves, or be taken, transported by someone else. I do not recommend that you be the one who transports them, but you do want to ensure that they get there. But if they're not voluntarily willing to go for an assessment by the appropriate individual, you'll need to call local law enforcement to initiate the process. And it will depend on where you are. If you're not within some municipality, you probably will need to call a sheriff's department. If you're within a municipality, then you would call the city police department. They will be the ones that need to transport that individual to the facility, the appropriate facility. Most likely they will take them to a hospital. You will want to identify yourself. You're breaking confidentiality, which is within the parameters of what you're allowed to do. Identify yourself, provide your credentials, and provide your assessment as to what is happening with your client and what you recommend. They will probably want to talk to the individual themselves in order to determine that this is something that they are at least willing to do. But they will be the ones to transport them to the facility. They will take them to the facility, and that's where, if they have not already been assessed by the psychiatrist or psychologist or even just a general medical doctor, they will receive that first evaluation there at the hospital. If that individual determines that they warrant hospitalization, that they are an imminent danger to themselves or someone else, then they will be processed to the facility in which they will be held for a minimum of 72 hours during this commitment. When they arrive at the facility, and it could be at at another place in that same hospital if they have the appropriate resources, or they will refer them to a facility that handles crisis stabilization. Private psychiatric hospital, another state-funded hospital, facility, private hospital, depending on insurance provided. It really depends, but they're the ones that make those determinations. So if they say yes, they will take them to the second facility that will be the facility that actually houses them for the 72 hours. And there they receive a second evaluation. This is that second prong, the second step. And if that next individual also determines that, yes, this warrants hospitalization, they sign off on it, and the person is then detained behind a locked door for 72 hours, a minimum of 72 hours. And that's the process. It can be extended as time goes on, and in my opinion, as times have changed and what third-party payers pay out to facilities, then this time period has decreased over time. As I mentioned before, it used to be that the standard length of stay was about a month when it came to hospitalization. It was always that initial 72-hour period, but then insurance would pay for 30 days. But these days, it probably will max out at maybe a week, maybe 10 days. But the 72 hours are kind of guaranteed through this legal process of involuntary commitment. So that's the process procedure when it comes to ensuring someone's safety. And I personally like the fact that there's multiple steps built in just so that a person is not detained when they do not need to be detained. But certainly there are times in which people can fall through the cracks as well. They might, in your presence as a clinician, they might say to you, yes, I plan on killing myself, and then they go to this next place for their first or second assessment, and they'll convince that person that, no, they do not intend on killing themselves any longer, and then they're released. So people can fall through the cracks, but maybe it's also a process of them realizing the seriousness of these types of thoughts and going down this road that it maybe does change their mind along the way. So if you determine that the person is at a risk, but you are not very convinced that they are of imminent danger to themselves or someone else, that they're maybe having some passive thoughts about suicide, which lots of our clients do have from time to time. If you determine that they are not going to be at risk, that you feel okay with letting them leave your office, one of the things that you will want to do is develop a safety plan. Now, this does not equate with a contract, which I am not in favor of as a clinician. I do not believe that if you put something in writing and have a client sign on it that essentially says, I promise not to kill myself, I take no stock in that type of document. I do not trust it as something that would bind anyone to keep them from killing themselves. So I encourage you not to think in terms of safety contracts, safety contracting with someone. I encourage you to develop a plan with them. So if you feel like there's a risk, but not great enough for hospitalization, develop a plan with them, in conjunction with them, for how they will remain safe. What will they do if they feel like they're starting to have thoughts that are concerning? Essentially, it comes down to them knowing what to do, how to reach out for help, how to communicate, how to involve others when it's possible, how to reach you if needed. So do not rely, don't trust a contract. This is not going to be something that stops someone from killing themselves. What you do want is for your client to know what to do in an emergency, that safety plan. As I mentioned before, if you find yourself to be a school counselor, you're probably going to have very specific protocol that you'll need to follow. And that's aside from developing a safety plan, the slap dirt or sad persons. There'll be a specific assessment that your school system will want you to complete. In general, if you're going to think about making a mistake when it comes to suicide assessment, I want you to err on the side of caution. It will be a lot easier to repair a relationship with your client, to backpedal later if you feel like that client is at risk and you commence proceedings for perhaps hospitalization, and they get angry at you because of that. To me, it's worth losing a client. Not losing them to suicide, but losing them as a client in order to ensure their safety. You can attempt to make amends with them, to apologize, to try and repair communication with them, to backpedal in that relationship. You can do that when they are still alive. You can't do that if they've killed themselves. And I guarantee you that if you lose a client or a student to suicide, this will take a significant toll on your career as a human being. So you want to really ask yourself how sure you are regarding their safety. And when it comes to all these elements, when you're encountering clients who are potentially suicidal, potentially at risk and danger, document every step you take along the way. And this is not a means of covering yourself. This is helping everybody out along the way, so that should this type of behavior crop up again in the following year, you have documentation of what happened, what steps you took, the level of severity, everything that potentially could be helpful to that future clinician to ensure that client's safety. The side effect of documentation is that you do have coverage should something happen, but that is not the intention behind documenting all these things.